This is MD Roundtable, a podcast about collaborating and learning from healthcare professionals from all over. We are all so much more connected due to technology. We have so much to learn from each other. I am Dr. Ted Thatchencary. Thanks for joining me. Thanks for joining us today at MD Roundtable. This is a very special episode as we are featuring Dr. Nahreen Ahmed, who is an assistant professor of clinical medicine at the University of Pennsylvania, as well as a global health scholar at the Center for Global Health. She is a board-certified pulmonary critical care physician, and I would also say she's a guru in point-of-care ultrasound. Welcome to MD Roundtable, Dr. Ahmed.
Thank you so much for having me.
Great. First off, Nahreen, why don't you tell us a little bit about yourself? For example, where did you grow up?
Yeah, thank you so much for asking. So I grew up in the Philadelphia area. My family is from Bangladesh. My parents immigrated here about 40 years ago. And although I was born and brought up in the US, we've gone back several times as a kid. And that was really my first exposure to resource limited areas of the world. And even though I grew up in the States, I've always been so connected to Bangladesh. I stayed here for college and medical school. I went to University of Illinois in Chicago for residency. And then that was my first real exposure to traveling as a physician in global sites to practice and really get exposed to clinical medicine at that time in low resource settings. And then from there, I went to fellowship at NYU in New York City. And that's really when my global health career kind of kicked off with some projects there in point of care ultrasound, which I'm sure we'll talk about. And so, yeah, so it's been an incredible experience, and the real connection, which I always love to share, for me was that for me, medicine has always been a bit of a legacy. My family were chock full of doctors, which I suppose fits the South Asian stereotype, but it's so much more than that. My paternal grandfather was a surgeon in Bangladesh who, was unfortunately killed during the Liberation War. But his commitment to providing care for the under-resourced areas of Bangladesh for folks who did not have access to medical care, that legacy lived on through my dad, who mom and dad both went to medical school in Bangladesh and continued to want to give back. And that's why they brought us back so many times. And seeing that discrepancy in healthcare at such a young age, it really left a huge impact on me to really motivate me to go into medicine and to be able to do something similar and give back. And so that's kind of the backstory of how I got here.
That's great, Nahreen. Thanks for sharing that. Yeah, it sounds like your early experiences as a child going back to Bangladesh really kind of shaped, who you are today. Would you agree?
Oh, I would totally agree. I think the importance of really learning about one's culture and how to be a part of it in a new and different way as somebody who's born and brought up in the States was an incredibly life-changing experience. And then to also have the medicine part of it be a part of that as well really shaped how I chose all the decisions I made in my career.
Great. What have been some of your biggest challenges that you've had to overcome?
Whew, that's a big question. I'd say there's several answers to that. I think the first big challenge that I faced was really just being a person of color and a woman in the field of medicine. That was sort of one of the first big challenges I think that I really, really felt as I grew into my career, and how that really, and especially being a woman, the challenges that come in our field. Although I don't have children nor am I married, my colleagues who are, I really see and feel, and it resonates, how that is a huge challenge, not finding the space to be a mom or a partner in the field of medicine. And that, I think, is a very big challenge. Of course, just in the field of global health, I think that was the next big challenge that I faced, which was there really wasn't a career path that, especially for somebody in pulmonary and critical care, as I chose what I wanted to do for my subspecialty, it was really interesting to see that all the options for global health pathways disappeared. And at a very early part of the differentiation of my career, I realized that this was going to be hard because I would have to kind of create my own path. Typically in global health, what you see is that emergency medicine, infectious disease, family medicine, these are the traditional pathways into global health. And so I was really discouraged by that at first, and then had some incredible advice that came my way, which was mostly that, just because the pathway doesn't exist doesn't mean it can't. And so that was a really eye-opening experience for me. But those are, I would say, were the two very big challenges is just navigating medicine, being part of a diverse background, and really understanding what that means, what that brings to the table. And then two, just really navigating a new pathway into global health from the aspect of pulmonary and critical care.
Great. Thanks, Noreen. How did you get involved specifically in point of care ultrasound and utilizing that with your global health career? Can you also sort of elaborate for the audience what POCUS is?
Absolutely. So I'll start by answering the second question first. So point of care ultrasound is the utility of age-old technology. So most people know ultrasound as what we use to look at babies when women are pregnant. In the last 10 to 15 years, especially pioneered by the emergency medicine folk, ultrasound started to become more portable and started to be used for many other functions, such as looking at the heart, looking at the lungs, and it's a quick way that diagnostician or the clinician, meaning the physician at the bedside or nurse practitioner or physician assistant, can use the ultrasound, look at any one of the organs of interest, find something that's helpful towards the diagnosis and act on it quickly. So it's using an age-old technology in a very new way that has allowed us to just gather more information about the patient very quickly and immediately at the bedside rather than waiting for somebody else to do the ultrasound and then to tell us what the ultrasound shows. Instead, both of those steps are now done by the clinician. And so that was a brand new concept to many of us as we were coming up in training. I first was exposed to it in residency. My fellow, who was the person that was training me in the ICU when I was on my first rotation in the ICU, he had just come back from a very lively training. Was so excited to show us all about point of care ultrasound. At the time, I kind of thought, oh wow, like there's no way I'm going to be able to learn this. This is so comprehensive. I then went on to fellowship in New York City. In fellowship training, it's pretty much mandatory for everybody to go through ultrasound, some basic ultrasound training. It's almost like a boot camp that's done in New York City over the course of a few days. This is when it really piqued my interest that just over a course of a few days, I can learn so much. And if I continue to practice, I can really retain that. And I was able to prove that, and we all were over fellowship over the following few years, that in just a few days, we could learn so much about ultrasound. And then if we continued to use it, we could really graduate from fellowship with competency. And so that to me started to translate into how do I now, as a pulmonary critical care doctor in training, figure out how to bring medical education in a creative way to low resource areas. And it started with a needs assessment. And so in truth, I didn't actually start out thinking point of care ultrasound was going to be my foot in the door in global health. Because my family and my parents had trained in Bangladesh, I had a existing network there. So that was a lot easier to tap into. And basically, in speaking to many of the physicians in the ICU there, realized that even just a portable x-ray is not always available. And so diagnostic
Mhm.
imaging is really lacking. And then just having a portable ultrasound for them would be, really impactful for their day-to-day care. And so that's kind of what launched everything. And once that idea kind of popped into my head that, okay, let me see if I can mimic what I went through here in the States, in New York City, and with my ultrasound training. Can I mimic that in Bangladesh? Can I get a machine and can I train folks up and then those folks train others and can this become sustainable? So that was sort of the first project that launched and that has now been self-sustained and very successful for almost 7 or 8 years.
That's great. That's amazing. I think it would be beneficial to discuss the Bangladesh Ultrasound Initiative that you're involved with for our listeners.
Yeah, so the
Do you
Bangladesh,
want to
yeah.
tell us a little bit about that?
Yeah, of course. So that was the Bangladesh Ultrasound Initiative was really my first foray into training in ultrasound and doing it abroad. And so because, as I mentioned, the network being something that I already had in Bangladesh, that's kind of where we started. And it started in the intensive care unit at a large public hospital, the Dhaka Medical College Hospital. And the reason that that was the decision to kind of start there was because many medical students go through there. It's a rather prestigious medical college and hospital, and it sees the most amount of patients in the capital city. And so, really, the pathology we knew was going to be varied. And so, it wasn't very hard to convince anybody that this is something that's needed. We sort of went in and when we talked about diagnostic imaging being absent, we kind of talked through, okay, what are some of the different things that you might want to see? And before I could even mention it, ultrasound was brought up. And so that to me was fantastic because I didn't want to come in here and say, hey, you need this. And it was something that as a discussion and a conversation, it turned into this is something that could be really beneficial. So how that started was actually we started recruiting physicians, mostly one of them to be with a critical care background so that this could be a device that sits in the ICU. But that was also just the beginning. It was sort of an introduction of this is point of care ultrasound. We're just starting to introduce it in the ICU, but it can be used literally anywhere in the hospital. And so our initial cohort of people was about 50 trainees.
Oh,
And,
wow.
and it was a lot. And I recruited several trainers from Bangladesh. There were two other Bangladeshis, one other American trainer, and so it was a phenomenal first run of this to say, hey, like this is something that's really cool, really necessary, and the buy-in
Mhm.
happened almost immediately. Everybody was just so engrossed by the utility and application of the device and point of care ultrasound, and the future of it in country really became apparent. So then the next year, and I just started to go back every year. I would spend a month in
Mhm.
Bangladesh every year. I identified three guys who were these were the guys that were going to lead the show. They said, you know what, we want to take this forward. And so, in any program, you want it to go so well that you're not needed anymore, which was kind of the goal. So when we identified these three physicians and they were so motivated to take this forward, and they really did. So when I left, they continued to practice. I spent a significant amount of time with them. It sort of mimicked what we call a train the trainer approach, and
Mhm.
they were going to be my three master trainers. And so moving forward, they would train, the equivalent of residents. They would train residents that were coming up, and every year that I would go back for that 1 month period of time, I would sort of have a new fresh class of people. That would be sort of the boot camp, and then they'd resume all of the training that they were already doing. And so by the time every year subsequently that I would go back, our class size would be anywhere from 25 to 50 based on the number of trainers that we had. And they were just getting better and better. I mean, by the time I showed up, I was like completely
Mhm.
not needed by the third or fourth time around. And now they really don't need me at all, but which is
Mhm.
fantastic. And then what
Mhm.
ended up happening after that, because the importance of just word of mouth and people in the in the medical community, it's a rather small community no matter where you go, and people across hospital systems were talking about point of care ultrasound. And we had done some one-off sort of introductions to point of care ultrasound in other hospitals, and so this kind of gained interest of those who were tied to the government. And actually, there were about 9 of us sponsored to come. This was the February right before COVID, to come to a
Mhm.
huge conference that was for physicians from all over the country. People flew in from every district of Bangladesh to come attend this course. And that was incredible. That to me showed, okay, the country wants to move forward with this type of
Mhm.
training and make it a part of the curriculum. So that's how it started. And that's where we are now. And hopefully,
Yeah.
as COVID kind of clears a little bit and things are sort of starting to go back to quote unquote, the new normal, we're, really looking forward to implementing point of care ultrasound, even at the level of medical school, which I think would be incredible. And it's kind of, it's the path that we've taken here in the US. It seems to work. And so that's kind of what we're trying to build from the bottom as well as from the top.
That's great, Noreen, because I mean, the fact that you kept going back and made this sustainable is just so inspiring, to myself.
Thank you so much for saying that. Yeah, it was really a labor of love. I mean, certainly it does help that I speak the language and not not very well, but well enough. And there's a family tie there for me. And so I think,
Mhm.
when it comes to global medicine, having some personal connection, whether it's family, not family, just sort of a personal motivation to keep going. I think that is where the success happens when people feel connected in some way.
Mhm.
It doesn't always have to be a family connection because that would be impossible. But for me, it just got very lucky that that was the coincidence in this case. And in most of the other sites, it just it starts to really feel personal as you start to meet people, and it's hard to walk away and say, I'm not coming back, and I can't, help you anymore. And so it's a fear of mine anytime I start a project, that if I go into it, I have to be able to tie this up and say I've done everything I can to be helpful.
Right. How many devices have you been able to donate over to Bangladesh and Dhaka Hospital?
So that actually, the donated device was actually the first one. After that, everybody kind of their hospital systems bought into the concept of point of care ultrasound, and I just connected them with the regional distributor. So
Got
so the very, very first device that went was the Sonosite M Turbo.
it.
And
Hmm.
kudos to Sonosite for even taking my call. They're wonderful, and they discounted a brand new device that normally would go over 20,000, and I got it for about $10,000. And so I crowdsourced that device and then donated it, and it's still in good shape. Thankfully, there is a regional distributor there, and so they can kind of fix it up every now and again. But because that device, and then we would bring because again having like a regional warehouse or a regional contact is great because they brought
Hmm.
loaner devices to the trainings. So to have that many people, sure, people are wondering how could you possibly train 50 people with one ultrasound? They would bring several more ultrasounds to loan us for the training sessions, which was phenomenal. And then the hospital system just kept saying, you know what, like we have to get more of these. And so, and because the key is in many countries, the finances in hospitals, certain things just aren't prioritized, or especially in government hospitals, it's
Right.
challenging. There's a lot of bureaucracy, and that's everywhere in the world. So to prioritize something that people weren't sure about, that was hard. So then as
Hmm.
the hospital leadership started to see like this is a very impactful device, it could do a lot. There started to be more allocation and prioritization of getting ultrasound devices across the country, across the city. So that really, the power of that was pretty amazing. And so that's actually the first device was the only donated one. And after that, everybody else was pretty motivated to get on finding funds to get more. And that was part of the sustainability that
That's
I
great.
had to
Yeah.
say, like, I cannot come here with 10 donated devices. Like, we have to figure out a way to make this
Mhm.
work within the confines of the resources that we have in country.
Yeah, it certainly helps when you have buy-in from the local hospital.
Completely. I don't think I realized how important those first few conversations are. I got a lot of flack at first for being somewhat disappointed when I had to shake so many hands and do, TV interviews and newspaper interviews. And I said, I'm here to focus on the work. And somebody said to me, no one's going to hear about it if you don't talk about it, if you don't shake the hands of the people that are going to be allocating the funds later. They have to know who you are and what you're doing and where you're coming from. And as a young, active person who just wanted to get to the clinical and medical education work, that was a real lesson for me that, you really do have to put in the time of building the story of like, why am I here? What am I doing? How is this actually going to be helpful? Do they, is this something people actually want?
How do you balance your academic career with your global health career?
It's a great question.
That's always a
Yeah,
challenge,
absolutely, absolutely. I laugh because this is I actually just I gave a talk to residents who were interested in global health just yesterday, and one of the points I really tried to make was that that balance is so important, and that balance is predicated on being able to find salary support. I mean, the truth of the matter is, many of us graduate in full transparency. Many of us graduate medical school with a load of debt. And it's not that residency and fellowship pays enough to necessarily pay off debt. So when we become attending physicians and we finally get our salary and we're so excited, like, yes, we can finally put money towards buying a house and start to work on my loans a little bit more. And, then, how is it even feasible to say, I'm going to then choose an option that cuts my salary, which is what happened with me. I basically, global health doesn't pay very much. And what I chose to do was I actually chose to say to my employer, I'm going to work 80%,
Mhm.
and the other 20% I'm going to take as my own time to work on my global health work. As that grows, I'd really like to figure out a way to finance that in a more sustainable way than just doing extra moonlighting shifts. And so that's kind of where the balance comes financially for me right now. And with critical care, much like emergency medicine, it's a lot like shift work. So even though I'm doing 80%, that's not necessarily working every single day, but we have sort of bursts of very high intense work and then sort of those breaks in between. And so it works for me for now, but the balance, I think, over time is going to come from finding steady salary support. And, really that comes from either a nonprofit that you're working with or the institution itself, and finding ways to strike a balance between providing education for residents and medical students and that kind of being a part of how we get supported for that. And so I think that's something that it's so important because people don't talk about that. They don't talk about that. No one as a resident or fellow talked about FTE. What is what is the percentage, of your 100%
Right.
FTE? Where is that money coming from? And if you wanted to do something else, how would you do it? These are really practical questions because as physicians and we grow into our careers, we also realize that clinical medicine, while is the reason we all went into it for the most part,
Hmm.
can really be taxing on us emotionally, physically, and over time, our interests grow and change. And how do we then, mold our careers to allow us to do that and still get paid enough to like live in a house and pay off our loans and do all of that and raise our kids and all those kinds of things. And so, yeah, the balance is challenging. And at this moment, I'm still sort of balancing it with doing some extra moonlighting shifts here and there, but constantly negotiating different ways to balance that on a financial level. But it's always a challenge.
It is, and thank you for speaking on that because I'm sure that's a question that a lot of people have. So thanks for clarifying
Oh,
that.
definitely.
How do you, Noreen? How do you continue to learn and stay up to date in this field?
Oh, that's a great question. There are so many resources out there, and I've had the pleasure of working with some of the smartest people in ultrasound. I love to teach it, but the innovation that comes from ultrasound, I'm constantly learning that from other people who are, the geniuses in really innovating and re-innovating how we're using this device. And so I really learn from my colleagues. I have, I at Penn, there are phenomenal ultrasound educators there. I'm constantly learning from them. And in fact, every time I teach a course, I go back to the basics. I relearn everything myself because it's an important way to kind of get back into the language of teaching, which is different than just performing an ultrasound myself. And so I like to go back and review PowerPoint slides and quick lectures that exist all over the internet. And there's some great resources. Core Ultrasound is a great one with Jacob Avila. Global Ultrasound Institute is a phenomenal resource, and we use that quite a bit at Med Global as our collaborators to provide the medical education in a platform that's easily reachable online. And so I go back and I look at some of that content, and that's how I sort of keep up to date in point of care ultrasound. Every time I use the device, I learn something new. And then the last part of that is every time I teach somewhere else, folks in Bangladesh have taught me so much. I go back and I leave a device there, and when I come back,
Hmm.
they've already come up with 10 other ways to use it or have learned things that I never taught them and I myself maybe don't know. So it's really such an interesting and growing field. For instance, the biggest project that I'm working on right now, sort of in the new phase of it, is really thinking about how to use ultrasound to identify high risk dengue patients. Dengue fever is a huge problem in many parts of the world, very high mortality, and can often progress to dengue hemorrhagic fever. And identifying those patients early on to get them to
Hmm.
hospitals where they can get proper care. It's something that's been published previously, mostly in children, but hasn't really been explored in adults and in a more proper way. And so really thinking about, there's so much ultrasound research out there about how people are
Hmm.
using it in different ways to try and save lives. And I think trying to really pick apart some of those novel uses of ultrasound, that's sort of the next frontier for me. I think I think really
Great.
trying to find those algorithms and things that we can apply in other low resource settings is a really exciting area.
Very exciting. What are some of the things that well, you sort of talked about that, but are there other things that excite you right now in this field?
Oh, wow, that's a great question. Absolutely. I think probably the biggest thing that excites me right now is the ability to teach remotely. COVID was the biggest disaster that ever happened to many of us in our field, and especially in critical care. I mean, we got demolished, but the
I
piece of
concur.
yeah, the hope that came out of that was when we were grounded and unable to train folks in person, we started to really rely on the internet. Can we use that Zoom and other things like this to impact or teach in the same way that we used to? And the answer is, you definitely can't. It's not exactly the same as being in person, but there is so much we can do remotely. Right now, our team from Med Global has a response, and Med Global being one of the nonprofits that I work with, we have a response in Ukraine, and one big part of the response in Ukraine has been distributing point of care ultrasound devices. We are currently using the Butterfly device because of its portability and its cost effectiveness, and the ability to distribute those devices and then teach people remotely, I mean, is incredible. And just an example of that, we had a team that was actually, they were physically in Ukraine. We had distributed devices farther east, closer to the front line. And our team had done a remote training from, and they could have been in the US, but they happened to be in Western Ukraine at the time. And immediately after this training session had completed, one of the physicians that had the Butterfly device found a pneumothorax, saved a patient's life in the field. And that was incredible. So to be able to get that kind of feedback, we don't have to physically be somewhere, that there is a whole new world of training and spreading the impact of this in a way that means we don't physically have to be everywhere in the world. I think that's huge. As much as I love to travel, to full transparency, 50% of the global health is I love exploring new parts of the world and meeting new people and things like that. But the truth is that from a voluntourism perspective, we really have to minimize our footprint and allow and push and empower people in their own countries and support them rather than physically go and create a footprint there that maybe isn't necessarily needed. And I think that's the most exciting part to me, is how can we revolutionize how we approach global health and support and health equity, and how can we do that with the fact that we've been able to do so much of that over COVID. Like, now let's translate that into normalcy.
Great. Thank you, Nahreen. If you had to sum up what point of care ultrasound is for our listeners, how would you summarize it?
I would probably say that point of care ultrasound is almost a sixth sense. It's the additional. It's basically an additional brain for the physician, right? It's an additional set of eyes, an additional whole nervous system that we can add to our toolbox, a kit that allows us to see inside of the body right then and there. That as we listen to the heart, as we listen to the lungs, that now we can actually see the heart. Now we can actually see what's happening in the lungs. It's an added dimension to what we can see in the patient. It allows us to get a more 360 view and a more comprehensive view of the patient in the moment. And that means that we can understand a little bit more about what's going on with them in the moment, and a little bit more about how to help them in the moment. And so it's really just an additional set of eyes and ears, almost like an X-ray vision for us, so to speak, that we can use right at the bedside. And so that's probably how I would summarize it. And really just one of the greatest innovations I think we've seen in our time in medicine.
Definitely, I agree. Well, thank you so much, Nahreen. I know you're very busy, but thank you for joining us today on MD Roundtable. And I just want to say that you are very inspiring, and just keep doing what you do.
Thank you so much. It's so great to be here, and I truly appreciate it. It's such an honor.
You're welcome. Folks, don't forget to leave a review of MD Roundtable podcast on Apple iTunes, and please don't forget to subscribe. Stay tuned for our next podcast coming to you from MD Roundtable. Thank you for joining me again today, and have a great day. This is MD Roundtable, a podcast about collaborating and learning from healthcare professionals from all over. We are all so much more connected due to technology. We have so much to learn from each other. I am Dr. Ted Thatchencary. Thanks for joining me.